Welcome to the deep dive. Today, we're getting into something really, really critical in healthcare, especially, when you're dealing with those high stakes, complex areas like surgery.
Absolutely.
We all see the amazing advances, but the reality is healthcare is incredibly intricate. Things don't always go perfectly, errors happen, outcomes aren't always optimal, and the whole system is under enormous pressure.
That pressure is.
Yeah.
Yeah, it's a huge factor. You've got increasing demand, patients who are often older, maybe with multiple health problems.
Morbidities, right?
Right. And then just the pace of new treatments, complex, often very expensive treatments. It all sort of combines, and it creates what a major report called out years ago as a quality gap.
A quality gap. Okay, let's really dig into that. That term sounds significant. Where did it originate?
Well, it was front and center in that big Institute of Medicine report, Crossing the Quality Chasm. You probably remember it.
Oh, yeah, the landmark one from the early 2000s.
That's the one. It really highlighted this disconnect. Patients weren't consistently getting, the right care at the right time in the right place. The core message was basically, look, we need to fundamentally redesign healthcare processes, the systems themselves.
So it's a shift, moving beyond just focusing on individual skill to looking at how the entire system performs. And that flows naturally into this idea of value in healthcare, doesn't it?
It really does. And our source material for this deep dive, this section from a surgical text, it really leans into this concept of value-based healthcare. It's an idea strongly associated with Professor Michael Porter.
Right, value for the patient, but also for the provider delivering the care.
Exactly. It's about achieving the best possible outcomes relative to the cost. And Porter, he laid out some core principles for building that kind of value-based system. If we want to really master this, we need to grasp these principles.
Okay, let's break them down. What are they?
Sure. He proposed 6 key ones. First, organize care around specific medical conditions. So think about all the services needed for, say, diabetes grouped together rather than just siloed departments.
Okay, condition-focused. Makes sense. What's second?
Second, rigorously measure outcomes and costs. But not just for one episode, for the patient's entire cycle of care.
Right, the whole journey. Crucial data.
Third, move reimbursement away from just paying for volume, fee for service, and align it with the actual value delivered. Better outcomes, better value, better reimbursement.
That's a big shift. Okay, number 4.
Fourth is systems integration. Basically, making sure the right patient gets the right treatment and the right setting, efficient matching.
5.
Fifth is about the geography of care, promoting centers of excellence, especially for complex conditions where volume and experience really matter.
Centralizing expertise.
Yeah. And sixth, integrate information technology. Use IT to connect all the pieces, track the data, support coordination, make it seamless.
You can really see how those principles, even if they came from maybe a U.S. perspective initially, are influencing healthcare everywhere now. The source mentions the UK's NHS as an example.
It does. Things like having a universal healthcare number, building integrated IT platforms, initiatives like Right Care, Right Time, Right Place.
Or choosing wisely UK, avoiding unnecessary tests and treatments.
Right. The common thread through all of that is trying to deliver patient-centered care and achieve outcomes that actually matter to the patient.
Okay. And a really powerful way to understand why these systems need this kind of redesign, and maybe where things often go wrong, is this field of human factors, or HF.
Exactly. This is where we really get into the human part of the system.
So what exactly is human factors?
It's basically a multidisciplinary field. It studies the interactions, the interrelationships between people, the tools and equipment they use, and the environment they work in. And the goal is to improve overall performance by understanding how things like teamwork, the design of the task itself, the equipment, the workspace layout, even the organizational culture and structure, how all those things affect performance.
And HF training is different from just learning the technical skills.
Very different. Traditional training focuses on, how to do the procedure. HF training focuses on the cognitive skills, things like situational awareness, problem solving, decision-making under pressure.
Right, mental game.
Exactly. And the interpersonal skills, communication, teamwork, leadership, resolving conflict. Skills that are absolutely essential for managing complex, high-risk activities, especially in a team environment.
And this whole field didn't even start in healthcare, did it? The source mentions aviation.
That's right. It really took root back in the 1940s in aviation. They started looking very closely at crew behavior, how pilots interacted with their cockpits, technical surroundings, and how changing conditions affected everything. And those core concepts emerged. Cognitive skills, Basically, being aware of what's going on, thinking ahead, and interpersonal skills, how well the crew communicated and worked together. Those became foundational.
Which led directly to things like crew resource management training, CRM.
Yeah, CRM.
Yeah.
Aviation developed that to explicitly build stronger communication within the crew, to create an environment where, even the most junior member feels empowered to speak up if they see a safety concern.
That's huge.
It is. And training crews to cross-check each other's actions, offer assistance proactively, address errors constructively without blame, and importantly, to debrief afterwards, learn from every flight.
So it covers communication, teamwork. What else?
It also directly addresses things like fatigue, which is a massive issue, perceptual errors like misreading a gauge or mishearing an instruction, and it emphasizes how management style and the overall organizational culture impacts safety on the front line.
It's really about acknowledging human fallibility, isn't it?
Yeah,
But then designing systems and training people to build in resilience.
precisely. And the text mentions some more recent developments too, like consciously designing systems and environments to minimize the chance of error, and even using nudge theory.
Nudge theory, that's Thaler and Sunstein, right? Behavioral economics finding its way into safety.
Exactly. The idea is subtly structuring the environment or the choices people have to kind of gently push them towards beneficial decisions, but without restricting their freedom to choose otherwise.
What's the example they give?
The classic one mentioned is using an opt-out checkbox for prescribing generic medications in an electronic health record. The default is generic, the cheaper, often equally effective option. It nudges you that way, but the clinician can easily uncheck it if the brand name is clinically necessary.
Clever. So, human factors, clearly vital for safety. But the source says the benefits go beyond just preventing errors.
Oh, absolutely. Understanding and applying HF principles doesn't just improve safety, it enhances the overall quality of care, accessibility, cost-effectiveness. It can even help with staff recruitment and retention. People want to work in well-designed, supportive systems.
Makes sense. So, if we were to boil down the key takeaways from this first part, the foundation, what would they be? The source has a summary box, right?
It does, basically. Healthcare is incredibly complex. Human factors give us a lens to understand the risks and find solutions by looking at behavior and its influences. Those influences can be identified and changed. A concept of value is critical for everyone involved. And maybe most importantly, HF training isn't a nice-to-have anymore. It's a prerequisite for safe, effective, modern practice.
Okay, that sets a really strong foundation. Now let's dive into the core focus of this material, patient safety itself.
Right. And this section really doesn't pull any punches. It confronts the reality that medicine, despite our best intentions and the first do no harm principle, is never going to be completely risk-free.
Even with all the advances.
Even with all the advances, the text highlights ongoing challenges globally. Unsafe practices still exist. You might encounter incompetent professionals. Governance structures can be poor. Errors happen in diagnosis or treatment. And sometimes there are issues with non-compliance with guidelines.
And when errors do occur, the system's response is absolutely critical.
It is. Effective systems have to do several things. They must inform and care for the patients and families affected. They need to rigorously analyze why the error happened to learn from it, and then, crucially, take steps to prevent it from happening again.
But it's not just about learning from mistakes, is it?
No, the material also stresses the importance of learning from what makes care safe. What are the facilitators of good outcomes? Patient safety has really grown into its own discipline now, with its own methods, design principles for health services, techniques for incident investigation, and a whole body of research.
And risk management is a core part of that discipline.
It is. Historically, risk management in healthcare was quite narrowly focused on patient safety and reducing medical errors. But again, because of that increasing complexity, we talked about new tech, IT risks, cybersecurity threats, the legal and regulatory environment.
Right.
Its scope has broadened significantly. The text points out that surgeons, especially, need to be aware of these wider risks and actively contribute to the hospital's overall risk management systems.
The source provides some really powerful data points on the impact of errors, doesn't it? Just to underscore the scale of this.
It really does. It mentions the IOMs to Errors Human Report from 1999, which was a massive wake-up call globally. More recent WHO estimates suggest that maybe 1 in 10 patients in advanced hospitals suffer some form of preventable harm.
1 in 10, wow.
Yeah, although they do caution that measuring this accurately across different systems is really challenging. But the financial burden is staggering billions every year from things like longer hospital stays, lost income for patients, disability litigation costs.
And that OECD report.
Right, the Economics of Patient Safety from 2017. It estimated that harm caused by medical treatment, Iatrogenic harm is actually the 15th leading cause of the global burden of disease, and it accounts for something like 15% of total hospital spending in OECD countries.
So this isn't a minor issue on the fringes. It's a core challenge with massive human and economic consequences.
Absolutely, it's universal.
And tackling something that huge, that systemic, it requires more than just tweaking things. It needs a fundamental shift in culture.
That's exactly the point the source makes. Effective patient safety and quality strategies can't just be top-down mandates. They require a genuine, whole organization culture change. You need commitment and leadership from the very top, from senior management, but you also need active engagement from everyone working on the front lines.
And a critical piece of that culture change is creating a blame-free environment.
Yes, this is crucial, especially for things like clinical audit, managing safety data, and encouraging incident reporting. The focus has to be on learning and improvement, not on finding someone to blame. If people are afraid of punishment or litigation, they simply won't report errors or near misses.
Because that fear is precisely why things often go unreported, right? People are worried about the repercussions.
Exactly. So clinical risk management needs to be seen as this integrated system-wide process, identifying risks, analyzing them, putting controls in place, and it absolutely has to operate in an environment of trust. A blame-free environment where data can be collected and learned from, both within the hospital and shared nationally.
Even patient complaints, which might seem negative, are actually valuable data sources.
Incredibly valuable. Complaints from patients or their families often shine a light on problems in care pathways or communication breakdowns that might otherwise be missed. When you analyze them systematically, they provide crucial insights for improvement.
And there's a move towards making that process easier for patients.
Yes, the text notes a growing trend towards easier, more effective complaint processes, often involving patient advocacy units that can help with information, mediation, or conciliation meetings. It's all part of recognizing that risk management is complex, it has operational, legal, financial aspects, but the core needs to be clinical risk, benchmarking performance, and learning from incidents to improve patient safety.
It's also really important to define what we actually mean by a patient safety incident. It's not the same as just the inherent risk of being ill or having a treatment.
That's a critical distinction the source makes. Medical risk is sort of the baseline risk, the risk inherent in the patient's condition itself, or the known, unavoidable side effects of a necessary treatment. A patient safety incident, however, is defined as a preventable event or circumstance that either did cause unnecessary harm or had the potential to cause unnecessary harm.
And there are different types.
Right, they break it down. Adverse events are incidents where actual harm occurred. Near-miss events are incidents where harm could have occurred but didn't, either due to luck or timely intervention. And no-harm events are incidents that reached the patient but caused no discernible harm, again, often due to chance or the patient's own resilience. Learning from all three types is vital.
And the source includes a table, doesn't it? Listing common factors that contribute to these incidents. It really shows how the human and system elements intertwine.
Yes, Table 15.1. Under the human factors heading, you see things like inadequate assessment or errors in diagnosis, failing to use or interpret tests correctly, errors in performing a task, inadequate monitoring or follow-up.
Experience level comes into it too.
Definitely. Training or experience deficiencies are listed, but also factors like fatigue, being overworked, time pressures, personal or psychological stress affecting the clinician, variations in the patient's condition or the immediate working environment, and even just failing to recognize the danger of an error developing.
And then there are the system failures listed alongside those.
Right. And this is crucial. Things like poor communication between different healthcare providers, and the text specifically flags this as the most frequent contributing factor listed in that table.
Really, communication breakdown is number one.
According to this source material, yes. Other system failures include inadequate staffing levels, reporting systems that are disconnected or don't talk to each other, over-reliance on automated systems without proper checks, poor coordination during patient handovers.
What else?
Issues with medications that look or sound alike, problems with the physical design of the workspace or infrastructure, equipment failure, maybe due to lack of parts or skilled operators, the impact of hospital cost cutting on resources, and poor governance or ineffective reporting systems.
Wow. That list really drives home the point that errors rarely happen in isolation. It's usually a complex mix of human factors interacting within a flawed or stressed system.
Precisely. It reinforces that whole human factors perspective we discussed earlier.
Okay, so we understand why incidents happen, this complex interplay. How does the material suggest we should approach understanding them when they do occur? And what strategies can we use to improve safety?
Well, the source presents two fundamental ways of thinking about errors and safety: the person approach versus the system approach.
The person approach. That sounds like the more traditional view, maybe more intuitive.
It often is. The person approach focuses on human fallibility. It acknowledges that people make mistakes, errors of commission, doing the wrong thing, omission, forgetting to do something, or execution, doing the right thing but badly.
Right.
The thinking here is often focused on the individual trying to prevent that person from making the same mistake again through retraining, discipline, etc. The big critique, though, is that this approach often leads straight to blaming the individual.
Which shuts down learning, as we said.
Exactly. It restricts wider organizational learning. Performance assessment in this model tends to focus on individual appraisal, maybe clinical audit, looking at individual results against benchmarks.
So the system approach flips that perspective.
Completely. The system approach starts from the premise that healthcare systems themselves are incredibly complex. They add layers of organization, technology, and process that actually amplify the potential for basic human fallibility to lead to an adverse event.
So the system can set people up to fail, essentially.
In a way, yes. From this perspective, adverse events are almost never caused by just one single isolated mistake by one person. The critical question isn't who messed up, but why did the system allow this to happen? Professor Don Berwick's 2013 NHS report is mentioned here as strongly advocating for this system-wide view.
Moving from pointing fingers to pointing at processes.
You got it. And building on that system approach, the text introduces another really important distinction: safety 1 versus safety 2.
Okay, safety 1 sounds like the traditional systems view we were just discussing, focusing on failures.
It's very closely related, yes. Safety 1 is the traditional view. It focuses on identifying errors after they've happened and then trying to put measures in place to stop them from happening again. The main focus is understanding what goes wrong.
Okay, so what's safety 2?
Safety 2 is a newer and I think really insightful perspective. It acknowledges the incredible resilience and adaptability that healthcare professionals show every single day. It focuses on understanding how everyday work actually succeeds, often despite the system's flaws, because clinicians are constantly adjusting, adapting, and working flexibly in really dynamic situations.
So it's about learning from success, not just failure.
Exactly. Proactive safety management, from a safety 2 viewpoint, is about understanding and enhancing the ways things normally go right, rather than solely focusing on preventing failures.
That's a really interesting shift. The source mentions a white paper from safety 1 to safety 2, saying we need both.
Precisely. Mature safety thinking requires embracing both ways of thinking. We need to analyze failures and understand why they happen, safety 1, and we need to study successful performance, resilience, and adaptability, safety 2. Balancing these two is seen as an investment not just in safety, but also in productivity and, importantly, staff well-being.
The text also brings in a couple of specific models to help visualize how errors occur within these systems. Heinrich's pyramid.
Right. Heinrich's safety pyramid. It proposes that major injuries to really serious events at the top are relatively rare, but they sit on a much, much larger base of minor injuries and an even larger base of near misses and unsafe acts at the bottom.
So the near misses are the warning signs.
Exactly. The model powerfully emphasizes why reporting near misses is so critical. They give you insight into the underlying risks and the chance to intervene before a major adverse event occurs. It's about understanding that whole spectrum.
And then there's James Reason's famous Swiss cheese model. How does that fit in?
The Swiss cheese model explains how adverse events often happen when multiple layers of defense within the system fail simultaneously. Imagine slices of Swiss cheese, each with holes in different places. Each slice represents a barrier or a safeguard in the healthcare system, maybe a policy, a checklist, technology, or a human checking step. Normally, the holes don't line up, but occasionally, due to various latent conditions or active failures, the holes in multiple slices align, creating a trajectory, a pathway, for an error to get all the way through and cause harm to the patient.
So each layer, each person has a responsibility.
Yes. The model highlights that every healthcare worker is responsible for the integrity of their slice of the cheese at their layer of defense to prevent errors from adding up. The more robust layers you have, the less chance there is of those holes aligning.
Okay, that's a really useful visual. So if we quickly summarize the key points from the source on understanding incidents, we've got the person versus system approach, with the system view being key because most errors involve system factors. Understanding why errors happen and applying lessons learned is vital for prevention. Reporting near misses and adverse events is absolutely critical for organizational learning. Models like Heinrichs and Reasons help us conceptualize error pathways. And adding that safety to perspective, examining what works well, is a really constructive approach.
That captures it perfectly. Now, the next step is translating that understanding into concrete strategies for improving patient safety and building that essential safety culture. The material is clear. Safety is everyone's responsibility.
And this happens at different levels, right? From the big picture national stuff down to individual hospitals and teams.
Absolutely. At the institutional level, the hospital level, it's about defining best practice within their clinical governance structures, benchmarking their performance against standards. The specific strategies will, of course, vary depending on local needs, the resources they have, the specific healthcare system context.
And there are big international efforts driving this too.
Yes, the World Health Organization, WHO, has been a major driver, especially since 2009, with their second Global Patient Safety Challenge, which was specifically titled Safe Surgery Saves Lives.
And that initiative gave us one of the most widely known and arguably effective safety strategies, the surgical safety checklist.
It really is presented as a cornerstone intervention. The original WHO study that introduced it across 8 very different hospitals showed significant reductions in both deaths around the time of surgery and major complications.
And later studies confirmed that.
Yes. The source mentions a large study in Norway, which found further reductions in complications, length of hospital stay, and mortality after the checklist was implemented there. The evidence for its effectiveness, when used properly, is quite strong.
And the source goes into the detail of what's in the checklist. It's not just a tick box, it's a structured communication tool tied to specific moments in the surgical process.
Exactly. It's designed around 3 obligatory time points where the team pauses and actively confirms critical information. The first is before induction of anesthesia.
What happens then?
Checks cover confirming the patient's identity, the surgical site, the planned procedure, and that consent is in place. They check the site is marked, if needed. Confirm antibiotics were given within the right time frame. Check the anesthesia machine and medications are ready. Pulse oximeter is on and working. Confirm patient allergies. Assess the airway and risk of aspiration. And evaluate the risk of significant blood loss, like is blood available if needed.
Okay, that's a lot, even before the anesthetic starts. What's the next pause point?
That's before skin incision. This is often called a timeout. Here, the entire team pauses. Everyone introduces themselves by name and role. They explicitly discuss anticipated critical events. The surgeon outlines the key steps, how long it might take, any anticipated blood loss. The anesthetist highlights any patient-specific concerns from their perspective. And the nursing team confirms sterility, equipment availability, and function. They also make sure essential imaging is displayed if needed.
So everyone's on the same page before the first cut and the final check.
That's before patient leaves operating room, sometimes called a sign-out. Here, the nurse verbally confirms the name of the procedure that was performed has been correctly recorded. They confirm that counts of instruments, sponges, and needles are complete and correct. Any surgical specimens are checked and correctly labeled, and the team briefly discusses any key concerns for the patient's recovery and ongoing management.
It's very structured, and the source notes it's adaptable too, like adding COVID checks.
Yes, it highlights its flexibility. Checklists aren't meant to be rigid documents. They can and should be adapted for local context or specific situations like the pandemic.
That level of detail really shows how it's meant to work. But the source also makes a really crucial point. A lot of errors happen outside the operating room.
Yes, that's a vital perspective.
Yeah.
Estimates cited suggest anywhere from 53% to 70% of errors related to surgery actually occur before the patient even gets to the OR or after they leave it.
So the checklist, while great in the OR,
Is only part of the solution. To get really substantial improvement in overall surgical safety, you have to target the entire surgical pathway from the moment of referral or admission, all the way through pre-op, the operation itself, recovery, ward care, discharge, and follow-up.
and the text adds another important caution. Checklists are tools, powerful ones, but they aren't a magic bullet.
Right. They function as simple reminders, memory aids. But their real impact depends on a deeper change in attitudes and on removing organizational barriers that might prevent teams from using them effectively or consistently. There's actually a danger if people start thinking that safety only requires ticking the checklist boxes and other important safety efforts get neglected.
So what makes for successful implementation? If a hospital wants to really make the checklist work, what does the source say is key?
It lists several critical factors. You need early engagement and genuine buy-in from the frontline staff who will actually be using it. You need active leadership support, visible champions who promote it. There needs to be extensive discussion, education, and training for everyone involved. It has to be multidisciplinary surgeons, anesthetists, nurses, technicians, everyone. Providing coaching during the initial phases helps. Establishing ongoing feedback loops is important. And as we said, allowing for local adaptation to fit the specific hospital and types of surgery is key.
Makes sense. Now, the strategies for patient safety. They can look quite different depending on the resources available, can't they? High income versus low or middle income countries.
Absolutely. The source acknowledges this reality. In resource-rich countries, you typically see strategies like strong regulatory systems for licensing professionals and facilities, national patient safety policies, standards set by professional bodies, established national audits and quality improvement programs, and often statutory requirements for reporting certain adverse events.
And in low and middle income countries, LMICs.
They share many of the same goals and face similar challenges, but often have additional, sometimes more fundamental issues. The probability of harm occurring might be greater. The risk of healthcare-associated infections is often much higher. Maintaining essential equipment can be a huge challenge due to lack of spare parts or trained technicians.
The source gives a really sobering example about injections.
It does. It notes that in some settings, unsafe injection practices, like reusing syringes or needles without proper sterilization, are still common, citing estimates of up to 70% reuse in some places. And this contributes to a massive burden of disease, estimating around 1.3 million deaths annually just from the transmission of viruses like hepatitis B, C, and HIV through unsafe injections. It's a stark reminder of how basic safety issues can still be paramount in many parts of the world.
A really powerful point about fundamentals. But the source also mentions that international collaboration can help bridge some gaps.
It can. Identifying risks and sharing solutions globally helps improve surgical safety and training everywhere. International collaborations, even informal ones driven by personal connections, can be really important catalysts for change. And the success of the WHO checklist itself shows that many impactful safety initiatives aren't necessarily hugely expensive. They often require focused attention on improving processes and care pathways, but always adapted carefully to the local context and resources.
And bringing it back to the hospital level, strong clinical governance is presented as the bedrock for safety.
It really is. Patient safety is fundamentally a team game, and the source emphasizes the importance of leadership training. Motivated, well-prepared teams are better equipped to reduce risks, especially if the organization manages incidents positively, focusing on learning rather than blame. High-performing institutions, it says, usually have transparent governance structures. These cover risk management, business planning, outcome reporting, and crucially, support for workforce education and ongoing training.
Okay, so summarizing the key strategies for safety that the source highlights. We have WHO initiatives like the checklist as important tools. Seeking external validation through certification or accreditation helps maintain standards. Engaging actively with clinical audits provides essential data for improvement. Collaboration, both locally and internationally, helps share knowledge and best practices. And fundamentally, hospitals with the strongest safety records tend to be those that foster robust governance, visible leadership, and effective team building to create that essential safety culture.
That covers the strategies well. Now let's delve deeper into the human element as it plays out in daily practice, particularly communication and professional responsibility, often centering on the surgeon's role as highlighted in the text.
Professionalism itself is listed as a component of patient safety. How is that defined here?
It's defined as the collection of attitudes and behaviors that consistently serve the patient's best interests. Professional bodies incorporate this into their standards of practice. And the concept of fitness to practice or competence isn't just about knowledge and technical skills. It explicitly includes attitudes and professional behaviors.
And who's responsible for ensuring that?
The responsibility is shared. It lies with the individual professional themselves, their employer or institution, and the relevant professional organizations or regulatory bodies. They often use transparent systems for identifying potential issues, monitoring performance, providing assistance or remediation where needed, and formal credentialing processes.
Open communication with patients and their families is stressed as absolutely fundamental.
It's presented as central to a truly patient-centered approach, where patients are seen as partners in their own care. Good communication is consistently linked to better health outcomes and fewer errors. And conversely, poor or inadequate communication is frequently cited as a major reason for patient dissatisfaction and even legal action.
And that involves patience and decisions, right? Especially around explaining risks, which requires real skill.
It certainly does. Respecting a patient's autonomy, their right to make informed decisions about their own body and treatment is paramount. But effectively explaining potential risks, the potential for harm, the likelihood, the alternatives is complex. Patients perceive and understand risk differently, and helping them weigh the potential benefits against the potential harms of different options is a core clinical communication skill.
Obtaining consent for surgery is probably the prime example of this critical communication. What does the source say is required for informed consent?
It details the essential information, often referencing a table, Table 15.2. You need to explain the patient's condition and why surgery is being recommended. Describe the type of surgery planned and how it's expected to help. Discuss the anticipated prognosis, recovery, and common side effects. You also need to mention potential, even if rare, unexpected hazards or complications associated with the procedure. Crucially, you must discuss alternative treatment options, including non-surgical ones, and explain the likely consequences if the patient chooses not to have the treatment.
The goal being an informed decision, freely made.
Exactly, without any coercion or manipulation. Ideally, consent should be obtained by the surgeon who is capable of performing the procedure, and it should happen when the patient is fully aware and has time to process the information, so for non-urgent cases, well before the day of surgery.
What are common pitfalls in the consent process?
The source notes, frequent causes of unsatisfactory consent include simply not allowing adequate time for discussion and questions, and failing to recognize that consent isn't just a one-off signature on a form. It's often a process, potentially involving multiple conversations.
And when things do go wrong, despite everyone's best efforts, open disclosure becomes necessary.
Yes, open disclosure, or sometimes called duty of candor. It's defined as honest, open communication with the patient and/or their family following an adverse event.
What does that involve specifically?
It includes giving a full and honest explanation of what happened, discussing the potential short-term and long-term consequences, outlining the plan to manage the situation and fix what can be fixed, ensuring the patient receives appropriate care and support following the event, explaining the steps being taken to learn from the event and prevent it from happening again, and, very importantly, offering a sincere apology and expression of regret for the harm caused.
Is this becoming more formalized?
Yes, the source notes it's increasingly reflected in healthcare policies and professional guidelines. It mentions the UK's General Medical Council, GMC, having a professional duty of candor, and that it gained a statutory basis in the UK following the Francis Report in 2015.
Okay, shifting back to the team dynamics. The text highlights situational awareness and emotional intelligence as critical for managing information flow and effective teamwork.
Absolutely. Poor communication within the healthcare team is identified as a major source of errors leading to misinformation, delays in diagnosis or treatment, failures in follow-up. Conversely, good teamwork, clear communication, and ensuring continuity of care are shown to reduce errors and also improve staff satisfaction and well-being.
So defining those terms, situational awareness.
Situational awareness is essentially being aware of what's going on around you in your immediate environment, understanding how information, events, and your own actions will impact your goals and objectives, both now and in the near future. It's about perceiving the relevant information, understanding its meaning, and projecting its implications forward.
And emotional intelligence.
Based on the work of Solovey and Mayers cited in the text, emotional intelligence is the ability to monitor your own and others' feelings and emotions, to discriminate among them, to label them accurately, and to use this emotional information to guide your thinking and actions. Experienced clinicians often use both intuitively to navigate complex, high-pressure situations effectively.
And these skills directly link to managing stress and preventing burnout, don't they?
They really do. Developing situational awareness helps you recognize escalating risks or demands. Developing emotional intelligence helps you recognize signs of stress or fatigue in yourself and in your colleagues. Stress, tiredness, fatigue. These are identified as significant risk factors, directly linked to an increased likelihood of making medical errors. They also take a toll on well-being, contributing to anxiety, depression, and just generally impairing cognitive function.
And burnout.
Burnout is described as that state of emotional, mental, and physical exhaustion caused by prolonged or excessive stress. The source notes it's a growing concern, particularly in the medical workforce, potentially more so than in other professions. Factors contributing to it include things like a perceived lack of autonomy, increasing administrative burdens, governance requirements, IT hassles, and regulatory pressures.
So the responsibility for managing this doesn't just fall on the individual clinician.
No, the source is clear. Organizations and their leaders have a significant responsibility to manage the working environment and practices to minimize fatigue and stress as much as possible. This includes things like workload management, scheduling, providing support resources.
Though the text does mention a potential trade-off with restricting working hours.
It does acknowledge that while legally restricting working hours for trainees, for example, is intended to reduce fatigue, it can also lead to an increase in the number of patient handovers and potentially a loss of continuity of care, which introduces its own set of patient safety risks. It's a complex balance.
Another specific high-risk area highlighted is medication prescribing.
Yes, medication errors are highlighted as being very common, and patients are vulnerable at multiple points in the process when the medication is ordered, when it's dispensed by pharmacy, and when it's administered to the patient. Accuracy is needed at every single step.
What are some common types of prescribing errors listed?
They include things like poor assessment of the patient or inadequate knowledge of their condition, insufficient knowledge about the medication itself, interactions, side effects, errors in calculating the correct dosage, problems with illegible handwriting on prescriptions, though electronic prescribing helps with this, confusion between drugs with similar sounding or similar looking names, and even errors related to the design or use of electronic prescribing systems.
Okay, so pulling together the key takeaways on communication and responsibility from this section. Communicating effectively and openly with patients and families is paramount. Understanding and utilizing situational awareness and emotional intelligence is vital for managing information and working well in teams. Professionalism encompassing knowledge, skills, and attitudes is a cornerstone of safe practice. And adopting a system approach is essential for managing risks and learning from complaints, moving beyond individual blame.
Exactly. And this leads us directly into the surgeon's specific role within this whole system and the broader frameworks used for quality improvement, or QI. Surgery, as the source reiterates, is inherently high stakes.
It really is. Invasive procedures. The source mentions over 100 million major surgeries globally each year. And in resource-rich countries, surgical problems account for roughly half of all avoidable adverse events.
Right. And applying that theory, we discussed that adverse events usually have multiple contributing causes, while many factors play a role in perioperative risk. The surgeon often finds themselves in a unique position.
As the team leader.
Typically, yes. As the likely senior leader of the operating team, the surgeon often plays a pivotal role in reporting adverse events, communicating what happened to the patient and family, discussing it with the team, and informing the administration. This is especially true for what the text calls coalface errors.
Coalface errors, what are those?
These are errors that occur right at the point of care, where the patient directly interacts with the surgeon and often identifies the surgeon as the person primarily responsible if something goes wrong. The source, referencing Kushiri, lists several types.
Such as?
Diagnostic errors, or errors in management decisions. Issues arising during resuscitation efforts. Errors related to prophylaxis like giving antibiotics at the wrong time or not at all. Prescription errors or mistakes with parenteral fluids or drugs. Failures in situation awareness, patient identification, or teamwork within the surgical setting. And then specifically, technical or operative errors made during the procedure itself.
The operating room environment itself is described as complex and prone to teamwork errors too.
Yes, it's painted as this intricate ecosystem with its own politics, social dynamics, cultural norms, even rituals and hierarchy, and potential for conflict. Effective systems need built-in defenses and well-prepared workplaces to try and prevent errors within this complex environment.
What are some well-recognized or are errors listed?
The classics, unfortunately. Operating on the wrong patient, the wrong side of the body, the wrong site, or performing the wrong procedure altogether. Failing to communicate critical information or changes in the plan during the operation. Disagreements within the team about whether or how to proceed. And, critically, leaving instruments or swabs inside the patient retained foreign objects.
And the source includes that stark image, doesn't it? An MRI showing a retained swab years later, figure 15.2.
Yes, a retained surgical swab found 10 years after a hysterectomy. It's a powerful visual example of what's often termed a never event. These are catastrophic failures, often stemming from basic breakdowns in communication or failure to follow established protocols, like the checklist counts. They underscore the absolute need for staffs to rigorously follow safety protocols and maintain a uniform approach.
Okay, let's focus specifically on technical and operative errors, the ones related to the surgeon's performance during the procedure. The source notes a slight difference in perspective here.
Yes, unlike many other areas where the system approach is now dominant, when it comes to technical operative errors, the person approach focusing on the individual surgeon's accountability often remains quite prominent, both in practice and in the medical legal sphere.
And the example given is bile duct injury during gallbladder surgery.
Exactly. Inadvertent common bile duct injury during a laparoscopic cholecystectomy. The source includes Figure 15.3, an ERCP radiographs clearly showing such an iatrogenic injury. While acknowledging that latent system factors like training, supervision, equipment should always be considered, this type of error often leads to scrutiny of the individual surgeon's actions, potentially resulting in targeted remediation like counseling or retraining alongside a reassessment of the system factors.
And avoiding these technical errors obviously links directly to surgical proficiency. How is proficiency described?
Proficiency is defined as an acquired state. It's developed and honed through teaching, deliberate practice, repetition, and experience, and it's characterized by consistently achieving good patient outcomes. The text describes it using concepts from cognitive psychology.
Oh.
High proficiency is associated with automatic unconscious processing. The actions feel almost effortless, intuitive. The surgeon isn't consciously thinking about every single micro-movement. This is efficient and less mentally tiring. Non-proficiency, on the other hand, relies on conscious control. Every step requires deliberate attention. It's slower, more effortful, and mentally fatiguing.
And the learning curve is that transition between the two.
Precisely. It reflects moving through what's called the hierarchy of competence, often depicted as a pyramid, Figure 15.4.
Can you walk us through the levels?
Sure. At the bottom is unconscious incompetence. You don't even know what you don't know. You're unaware of the skill deficit. Then comes conscious incompetence. You become aware that you lack a particular skill. This is often where formal training starts. Next is conscious competence. You can perform this skill correctly, but it requires concentration and deliberate effort. Finally, the peak is unconscious competence. You can perform the skill effectively and seemingly automatically, without conscious thought. It's become second nature.
And the text notes it's not bad for trainees to be at those conscious stages.
Not at all. It's a necessary and expected part of the learning process.
Okay. So what kinds of failures in operative technique are listed as contributing to adverse outcomes?
Several types are mentioned. Cognitive errors in judgment during the operation, like deciding too late to convert a difficult laparoscopic procedure to an open one. Procedural errors, like omitting critical steps in the operation. Executional errors, like clumsy tissue handling or using excessive force. Misinterpreting anatomy or pathology, which can be particularly challenging in minimal access surgery where the view is limited. Misusing instruments, like causing unintentional burns with diathermy. And failing to recognize an iatrogenic injury, an injury caused by the procedure at the time it occurs, leading to a delay in diagnosis and management.
And circling back briefly to never events, the definition is important.
Yes. Never events, or sometimes called serious reportable events, are defined as incidents that are considered largely preventable, because there should be strong systemic protective barriers in place to stop them from happening, things like the checklist protocols we discussed. They are events that have the potential to cause serious harm or death. Crucially, the harm doesn't actually have to occur for an event to be classified as a never event. The potential for serious harm due to the failure of those expected safety barriers is enough, and these events absolutely demand a full open disclosure process.
Finally, on the surgeon's role, the material brings up a really important, sensitive point. The burden on the surgeon when things go wrong, the second victim concept.
Yes, this acknowledges the significant professional, emotional, and sometimes psychological toll that managing adverse outcomes can take on surgeons and other healthcare professionals involved. This burden is amplified in increasingly litigious societies with changing patient expectations alongside the growing administrative demands placed on clinicians.
So surgeon well-being is a factor here.
Absolutely. There's growing concern about surgeon well-being and burnout. The source emphasizes that providing support for surgeons after an adverse event isn't just an individual responsibility, it's a community or institutional responsibility. The term second victim is used to describe the healthcare provider affected by the adverse patient outcome. The text is careful to clarify that using this term doesn't diminish the primary suffering of the patient, the first victim, but rather highlights that a truly comprehensive approach to risk management must be patient-centric, while also supporting the resilience and well-being of the workforce delivering the care.
That's a really critical point. The system needs to support everyone involved. Okay, let's pivot now to the proactive side. Quality improvement, or QI, how is that defined?
QI is defined as the continuous, combined efforts of everyone involved. Healthcare professionals, patients, families, researchers, payers, planners, aimed at making changes that lead to better patient outcomes, enhanced system performance, and support for professional development. It's not accidental. It requires intentional actions by skilled people, guided by data, and needs sustained commitment.
And improvement science is the discipline behind it.
Exactly. Improvement science is described as an applied science. Its focus is on identifying potential innovations or changes, testing them rapidly using cycles of learning in real-world settings, like PDSA cycles, and then spreading the changes that prove to be effective in specific contexts. The ultimate goal is to make care better across multiple dimensions, typically defined as efficient, safe, timely, effective, patient-centered, and equitable.
And value comes back into play here too.
Yes, value considering cost in relation to outcomes is seen as an important adjunct to QI, with an increasing emphasis on promoting health and preventing illness in the first place, not just treating sickness.
The scope of QI seems really broad. Where can it be applied?
Pretty much anywhere in healthcare. Activities can range from small-scale projects within clinical microsystems, those small, frontline, multidisciplinary teams we mentioned, all the way up to large-scale service redesigns affecting whole hospitals or regions. It also encompasses things like improving training programs, budgeting processes, or implementing new IT systems. Fundamentally, it requires staff to reflect on how they work, be empowered to improve it, and for the organization to cultivate a supportive QI culture.
And clinical audit is a key part of this.
Yes, clinical audit is presented as a core QI function operating within the broader framework of clinical governance. It's essentially a process of quality assurance, systematically reviewing care against explicit criteria or standards, and then implementing changes where practice falls short.
Where do audits happen?
They can happen at multiple levels. Nationwide audits looking at specific conditions or procedures, hospital-wide audits, audits within specific departments or specialties, even audits within individual GP practices.
And measuring outcomes through audit really helps drive improvement.
Immensely. The source lists several benefits of measuring outcomes. It directly helps improve the quality of care delivered, leading to better results, fewer complications, shorter stays, etc. It provides data for national audits and policy development. It supports shared decision-making by giving patients better information. It improves oversight for clinicians and teams. It helps specialty associations understand national performance. It supports individual and team QI efforts, often linked to appraisal or revalidation requirements. And it facilitates learning from high performers and spreading best practices.
The source outlines specific stages for a QI or audit cycle, table 15.3.
Yes, it breaks it down into 4 main stages. First, preparation and planning, defining the aim, the scope, the standards, who's involved. Second, measurement of performance, collecting baseline data on current practice and outcomes. Third, implementation of change, analyzing the data, identifying gaps, developing and testing interventions or changes using those rapid cycles. And fourth, sustainment and evaluation, embedding the successful changes into routine practice and continuing to monitor performance to ensure the gains are held.
And underlying all of this is measurement. Data is king in QI.
Absolutely non-negotiable. The source is emphatic. Without measurement, it's impossible to know if a change is actually an improvement. It also makes the distinction that QI measurement is usually about testing how to best implement or replicate known best practice in a specific local context, whereas traditional research is often focused on discovering what that best practice is in the first place. Quality measures are the specific tools used to quantify the quality of care.
And there are different types of these measures.
Yes, the text describes 3 main categories. First, structural measures. These describe the characteristics of the system or setting where care is delivered, things like staffing levels, for example, surgeons per capita, equipment availability, infrastructure like number of operating rooms, or the existence of specific policies. They're useful for looking at capacity, equity, and whether the basic building blocks are in place.
Okay, structure. What's next?
Second, process measures. These measure what providers do, the activities and tasks involved in delivering care, and how consistently they do them. Examples include things like the percentage of patients receiving appropriate preoperative assessment, adherence to medication protocols, or tracking operating room start times. Process measures are the most common type used for improvement work because you can often track them frequently, see variation, and link them to outcomes. They should, ideally, be linked to outcomes that patients care about.
Makes sense. And the third type?
Third, outcome measures. These measure the actual effects of care on the health status of patients or populations. They are the specific, observable, measurable results that show whether the QI project achieved its aims. Clinical outcome measures directly relate to the results of interventions, things like mortality rates, complication rates, infection rates, functional status improvements. Ideally, these should include patient-reported outcome measures, PROMs.
PROMs outcomes defined by patients themselves.
Exactly. Outcomes that patients themselves identify as important. The evidence should show that these outcome measures truly reflect the quality and effectiveness of the care provided. Outcome measures are heavily used in clinical audit for comparing results against standards or benchmarks.
And speaking of patients, involving them in designing the improvement work itself, patient-centered co-design is highlighted as crucial.
Yes, it's presented as a fundamental principle. Providers should actively partner with patients and their families to identify and prioritize the outcomes that are most important and desirable to them.
What are some examples of patient-defined outcomes?
The source lists several. Things like speed of access to appointments or treatment, the effectiveness of the treatment itself from their perspective, feeling continuity of care and having smooth transitions between different services, ensuring their family and carers are supported, receiving clear information and support for self-care, feeling involved in decisions and having their preferences respected, receiving emotional support and empathy, and having their physical comfort and environmental needs met.
It really shifts the focus and the power of data to drive all this improvement. The source includes those great quotes from the QI pioneers, doesn't it? Table 15.4.
It does. They really capture the essence. W. Edwards Deming, who pioneered the PDSA cycle, famously said, "In God we trust, all others bring data."
Huh. Love that.
Then there's the management guru Peter Drucker. What gets measured gets improved. Simple but profound. And Donald Berwick's description of the typical sequence of reactions people have when confronted with data showing a need for improvement.
Right. Walk us through that again. It's insightful.
It starts with denial. The data are wrong. Then deflection. The data are right, but it's not really a problem. Then diffusion of responsibility. The data are right, and it is a problem, but it's not my problem. And finally, acceptance and ownership. Okay, I accept the data, the problem, and the burden of improvement. That last stage is where real change begins.
That really highlights the psychological journey involved in using data for change. Now, to make this QI process even more concrete, the source walks through the typical surgical patient journey, pointing out all the opportunities for improvement along the way.
Yes, it describes the pathway for both elective, planned surgery, and urgent emergency surgery to illustrate just how many steps and handoffs are involved.
So for an elective patient,
It starts with the referral, then outpatient consultations, investigations, maybe preoperative surgical and anesthetic assessment clinics, then admission, which could be day case, same-day admission, or a short inpatient stay beforehand. Then preoperative checks on the ward, the journey to the operating theater complex, reception, anesthesia room, the OR itself, recovery room, the back to the ward, and finally discharge planning and transition home or to rehab.
and for an urgent patient.
They might present to the emergency department, self-referral, GP, ambulance, go through triage, get streamed to the right area, resuscitation, majors, minors, ambulatory care, be seen ideally quickly by a senior decision maker, and then either treated and discharged or need expedited admission and surgery, after which their pathway might resemble the later stages of the elective patient.
When you lay it out like that, you can instantly see dozens of points where errors, delays, communication failures, or inefficiencies could creep in. The potential for QI is huge.
Exactly. The source makes the point that the opportunities for improvement along these complex pathways are almost limitless.
So how do you approach that systematically? The source mentions a structured QI pathway.
Yes, it notes that QI can be applied anywhere, and improvement science provides the structured approach using innovation, rapid cycle testing, and spreading successful changes. It details a 7-stage pathway adapted from Healthcare Improvement Scotland, which provides a useful framework.
Okay, what are the 7 stages?
1. Discovering, defining the aims, understanding the problem, seeing what data is already available. 2. Exploring, mapping out the current state and visualizing the desired future state. 3. Designing, planning how to get from the current to the future state, prioritizing specific changes. 4. Refining, testing those changes using small, rapid cycles like PDSA, learning what works, assessing the benefits. 5. Introducing, communicating the plan changes, building motivation and a receptive culture. 6. Spread and demonstrating the improvements achieved, telling the story effectively and disseminating the changes more widely. And 7. Closing, capturing the learning, embedding the changes, and ensuring sustainability.
And for each stage, there are specific QI tools that can help. Table 15.5 lists quite a few.
Yes, a whole toolbox. The source groups them into organizational tools and graphical tools. Organizational tools include things like root cause analysis, RCA, to dig deep into why an incident happened, driver diagrams to visually link changes to desired outcomes, benefits, realization planning, demand and capacity planning, process mapping or value stream mapping to visualize workflows and identify waste or bottlenecks, and techniques like Kanban or 5S's for workplace organization.
And the graphical tools.
These are often used for analysis and display of data, things like fishbone or Ishikawa, diagrams for brainstorming causes of a problem, spaghetti diagrams to track physical movement of people or materials, various charts and plots for visualizing data box plots, frequency plots, scatter plots, Pareto charts to identify the vital few causes contributing to most of the problem, the 80-20 rule. And importantly, run charts and statistical process control SPC charts for tracking data over time to see if changes are leading to real improvement beyond random variation.
Okay, that's the pathway and the tools. What about the overarching methodologies? The source details several key ones, starting with the model for improvement.
Right. This is hugely influential, based on Deming's work, and popularized by the Institute for Healthcare Improvement, IHI. It's built around three simple but powerful questions. One, what are we trying to accomplish? Setting a clear aim. Two, how will we know that a change is an improvement? Defining measures. And three, what changes can we make that will result in improvement? Generating ideas for change.
And it uses PDSA cycles.
Exactly. The engine of the model for improvement is the plan, do, study, act cycle. You plan a small test of change, you do it, you study the results using your measures, and you act based on what you learned. Adopt, adapt, or abandon the change. It emphasizes small, rapid tests to accelerate learning.
Okay. Then there's lean methodology, different origins.
Yes. Lean originated in manufacturing, famously with Toyota in Japan. Its core philosophy is the relentless elimination of waste, Muda in Japanese, to maximize value for the customer, in our case, the patient. It uses a continuous improvement cycle, often called Kaizen, which is conceptually similar to PDSA.
And it defines specific types of waste relevant to healthcare. Table 15.6.
Yes, identifying these 7 wastes, though sometimes more listed, is key to applying lean thinking. The source lists: 1. Overproduction doing more than needed, like unnecessary tests. Solution example: evidence-based pre-assessment pathways. 2. Inventory excess supplies, drugs, paperwork taking up space and cost. Solution example: organized storage, efficient replenishment. 3. Waiting patients waiting for appointments, results, beds, staff waiting for information. Solution example: staggered admission times. 4. Waste of transportation, unnecessarily moving patients, samples, equipment. Solution example: better layout design. 5. Waste of overprocessing, doing work that adds no value, like using a CT scan for simple pediatric appendicitis when ultrasound might do. Solution example: consider ultrasound first. 6. Defect errors requiring rework, like incomplete paperwork causing delays. Solution example: robust checking systems. And 7. Motion wasted movement by staff searching for things like drugs or equipment. Solution example: standardized efficient OR layouts.
Identifying that race links directly back to defining value from the patient's perspective, doesn't it? And initiatives like choosing wisely.
Absolutely. Because waste, by definition in lean, is anything that doesn't add value for the patient.
What other methodologies are mentioned? Clinical microsystems.
Yes. Clinical microsystems theory views the healthcare system as being built up from small, interdependent, functional units at the front line. These microsystems are typically small, multidisciplinary teams who work together regularly to provide care for a discrete group of patients who are also considered part of the microsystem.
So like a specific ward team or clinic team.
Exactly. They share common aims, work processes, information systems. They produce measurable outcomes. They're seen as dynamic, living adaptive systems that evolve over time, and they are nested within larger macrosystems, like the hospital or health service. They're often assessed based on factors like the use of evidence, leadership, patient focus, staff focus, and information systems. QI efforts can be very effective when targeted at optimizing these microsystems.
And the last one mentioned is Six Sigma.
Six Sigma comes more from the business performance improvement world, famously used by companies like Motorola and GE, but it's been adapted for healthcare. Its main objective is a highly disciplined, measurement-based strategy focused on process improvement and, critically, reducing unnecessary variation or defects in processes.
And it has its own structured approach.
Yes, its core methodology for improving existing processes is called DMAIC. Define the problem and project goals. Measure the key aspects of the current process and collect relevant data. Analyze the data to investigate cause and effect relationships and identify root causes of defects. improve the process by developing, testing, and implementing solutions, and control the future state process to ensure deviations are corrected before they result in defects, sustaining the gains.
Okay, that covers the main QI methodologies. So pulling this all together, the final section of the source emphasizes the need for systems thinking and strong leadership to make all this happen sustainably.
Absolutely essential. Given the complexity of healthcare we've discussed throughout, systems thinking is crucial. You have to consider the whole system, the interconnections, the relationships between different parts, not just look at functions or departments in isolation.
Because healthcare delivery is so interdependent.
Exactly. It's a shared resource. Surgical success, for example, doesn't just depend on the surgeon. It depends heavily on anesthesia, critical care, nursing, pharmacy, labs, imaging, especially for complex patients with multiple health issues. If problems are systemic arising from these interactions, then the solutions also need to be systemic, focusing on relationships, integration.
Which brings us right back to human factors again.
Precisely. Communication, team building, conflict management, managing processes effectively, continuous education. These HF principles are key to systemic solutions.
And systems work best with the right culture and leadership.
That's the message. A non-punitive culture where learning is prioritized is fundamental. And you need leaders who understand this complexity, who actively champion and foster a culture of continuous quality improvement. Leaders need to be visible, engaged with the front line, and create a supportive environment where staff feel empowered to identify problems and test improvements.
And sustainable change. It can't just be driven by dedicated QI teams, can it?
No. While program teams are important, lasting change needs the support, drive, and ownership of the frontline staff themselves. Success requires keeping the focus on value for the patient, having constancy of purpose from leadership, and consistently applying systems thinking.
What enables that?
The source suggests it's enabled by having staff trained in QI methods, having leaders who practice humility, listening, and learning from the front line, and demonstrating genuine respect for every individual in the organization. It requires integrated strategies across all levels and a sustained long-term commitment.
The source does note that healthcare has maybe been a bit slow on the uptake compared to other industries.
It does mention that healthcare has, perhaps surprisingly, been slower than some other high-risk sectors to fully embrace and integrate QI theory and practice, citing Virginia Mason Medical Center in the U.S. as a notable healthcare example of long-term successful QI implementation inspired by lean principles.
And importantly, especially for our listeners who might be training or early in their careers, QI is becoming a core part of medical education now.
Yes, it highlights a 2016 report from the Academy of Medical Royal Colleges in the UK and Ireland, arguing strongly that QI should be a central, integrated thread throughout all medical training, from undergraduate right through postgraduate and continuing professional development. Mastering the skills to analyze and improve health systems and to implement evidence-based practice effectively within complex real-world settings are increasingly seen as essential competencies for all clinicians, including surgeons.
Okay, so summarizing these final key points on systems, leadership, and the future. QI is distinct from, but related to, clinical audit, using different types of measures, structure, process, outcome, to assess quality. The entire patient journey offers countless opportunities for improvement. Structured QI pathways, methodologies like MFI, Lean, Six Sigma, and tools provide the means to tackle these opportunities. Systems thinking, understanding the big picture and interdependencies is crucial. Visible, supportive leadership is vital for fostering a QI culture, and there's a clear need for more widespread QI education and training within healthcare.
That captures the essence of the final section well.
We have certainly gone deep today. We've covered the foundational challenges, the vital role of human factors in communication, the absolute necessity of robust patient safety strategies, different ways to understand errors, and the structured approaches of quality improvement, its models, measures, methodologies, and tools. We looked at the surgeon's specific role, the OR's complexity, proficiency, and the impact of errors on everyone involved. This deep dive, drawing out everything from the source, aimed to give you that comprehensive professional-level mastery of these interconnected topics.
It really underscores that being a skilled clinician today requires understanding far more than just the clinical science and technical skills. It's about understanding the systems, the human interactions, the culture, everything that surrounds the delivery of care.
Absolutely. So, to leave you with something to really think about, drawing on everything we've explored today, this intricate web of human behavior, system design, organizational culture, leadership, measurement, all essential for safety and quality, consider this. Which single element out of all of those do you believe is the most challenging to fundamentally change in healthcare today, and why?